Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I'll be doing a quick recap of this topic on the hypoglycemia. So, first question is, when is that you will call the word hypoglycemia? We use the word hypoglycemia when the blood glucose level is less than 60 milligrams per deciliter. And if you take the normal fasting blood glucose, that is normal fasting blood sugar, that is around 70 to 100 milligrams per deciliter, and the normal postprandial sugar will be around less than 140 milligrams per deciliter. That will be the normal blood glucose levels, and when the blood glucose levels are less than 60, we call the word hypoglycemia. Now, how do you classify the symptoms of hypoglycemia? The symptoms of hypoglycemia are due to, number one, excessive secretion of the epinephrine and due to dysfunction of the central nervous system. These are the two reasons why you have the symptoms of the hypoglycemia. Now, what are the symptoms due to excessive secretion of the epinephrine? The symptoms due to excessive secretion of epinephrine will be increase in the cardiac activity. In the sense, they will have tachycardia and they will have profuse sweating, because the epinephrine is the neurotransmitter which is released from the postsynaptic nerve terminals where there is profuse sweating. They will also have tremors, anxiety, and as well as increased hunger. So these will be the manifestations due to excessive secretion of epinephrine. And what are the symptoms due to dysfunction of the central nervous system? Symptoms due to dysfunction of the central nervous system, that includes dizziness, headache, blurring of vision, or we call it as clouding of vision, blunted mental activity, loss of the fine motor skills. Then the individual will also have confusion, abnormal behavior, convulsions, and loss of consciousness. So these will be the symptoms of hypoglycemia due to dysfunction of the central nervous system. So the symptoms of hypoglycemia, number one, it is due to excessive catecholamine release. Number two, due to dysfunction of the central nervous system. Now, the major symptoms of hypoglycemia will occur in a normal person. Does it occur? Yes. Even in a normal person also, the major symptoms of hypoglycemia can occur. But the blood glucose level, it should be less than 20 milligrams per deciliter. So major symptoms in a normal person may not be seen until the blood sugar is 20 milligrams per deciliter. Now, what is the cause of the postprandial hypoglycemia? The cause of the postprandial hypoglycemia will be secondary to elementary hyperinsulinism. This hyperinsulinism is the one which will cause the postprandial hypoglycemia. It may be idiopathic, we don't know what exactly is the cause, and as well as the galactosemia. So these are the causes for the postprandial hypoglycemia, right? Next. Now, what is the cause of fasting hypoglycemia? Fasting hypoglycemia can result from condition in which there is an underproduction of glucose, such as the hormonal deficiencies, that is panhypopituitarism and as well as adrenal insufficiency. Let me explain you this. See, hormones like corticosteroids, catecholamines, thyroid hormone, glucagon, they increase the blood glucose levels. If there is panhypopituitarism, there is no thyroid hormone. There will not be corticosteroids. There will not be catecholamines. So if there is no corticosteroids, if there is no thyroid hormone, and if there is no catecholamines, the gluconeogenesis does not occur, and thereby the blood glucose levels will not be maintained. So one of the cause for the fasting hypoglycemia will be the hormonal deficiencies. Adrenal insufficiency, that is addisons. So in addisons, there is decrease in steroid, and thereby there is decrease in gluconeogenesis, and thereby the individual can have hypoglycemia. Next, enzyme defects are another important cause. Substrate deficiency, severe malnutrition, late pregnancy can cause fasting hypoglycemia. acquired liver diseases. So whenever there is a liver disease like cirrhosis of liver, the hepatic gluconeogenesis does not occur, and that will make the individual to land up in hypoglycemia. Or the drugs like alcohol, propranolol, and as well as the salicylates can cause the hypoglycemia. So the causes for postprandial hypoglycemia is due to hyperinsulinism or galactosemia. The causes for fasting hypoglycemia will be the underproduction of the glucose due to hormonal deficiencies, substrate deficiency like severe malnutrition, acquired liver diseases, and drugs like alcohol. Now, you need to know what are the causes of the hyperinsulinism. The causes of hyperinsulinism is that this hyperinsulinism can occur secondary to insulinoma. What is insulinoma? I will discuss that. And exogenous insulin administration is another important cause for hyperinsulinism. Sulfonylureas are another cause. These sulfonylureas, they are insulin secretagogues. Right, they are insulin secretagogues, and they will stimulate the release of insulin, and that can make the individual to land up in hypoglycemia. And other important drug is the quinine, which can cause hyperinsulinemia or hyperinsulinism, endotoxic shock, and immune diseases with insulin receptor antibodies. So these are the causes for the hyperinsulinism. Right, hyperinsulinism can occur secondary to insulinoma, exogenous insulin, sulfonylurea administration, endotoxic shock, immune-mediated diseases with insulin receptor antibodies. Now, what is the effect of hyperinsulinism? Insulin is the one which will cause the glucose which is present outside the cell to make it to enter into the cell. So thereby, this will cause fasting hypoglycemia. Fasting hypoglycemia can also occur in conditions related to overutilization of the glucose, such as the hyperinsulinism. Now, what are the insulinomas? So, insulinomas, they are the beta cell tumors, and they cause the hypoglycemia. 90% of these tumors, they are single and benign. Right, 90% of these tumors, they are single and benign. And what are the clinical features of the hypoglycemia? The clinical findings include the symptoms of subacute or chronic hypoglycemia. And what are those clinical features? Such as blurring of vision. This will be due to dysfunction of the central nervous system, headache, feeling of detachment, slurred speech, and weakness. All these are mainly due to the dysfunction of the central nervous system. And symptoms can occur in the morning or in late afternoon or after fasting or exercise. So these are all the various periods during which the clinical features of the hypoglycemia can be present. Now, how do you diagnose the hypoglycemia? Right? How do you diagnose the hypoglycemia? See, whenever there is hypoglycemia, that is when the blood glucose level is like less than 40, what should happen to the insulin level? The insulin level should reduce. So, in a normal individual, whenever there is hypoglycemia, please remember the insulin production stops. Right? Insulin production stops whenever there is development of hypoglycemia. But here, in patients with the hypoglycemia, if the insulin levels are still high, that is what is suggestive of the hyperinsulinism. This is made by finding a serum insulin level more than or equal to 8 milligrams per deciliter in the presence of blood glucose less than 40 milligrams per deciliter. And this, it is noted either spontaneously or during the prolonged fasting state. This is how you will diagnose the hypoglycemia. Now, what are the imaging studies for detecting the tumor? The imaging studies for detecting the tumor include CT scan, ultrasound, and arteriography. These are all useful in detecting the tumor. Next, what is the management of the insulinoma? So insulinoma, it is a single and benign tumor. So that can be removed by surgery, or that can be treated by medical therapy like octreotide. Now we have a clinical condition called as the factitious hyperinsulinism. What is this factitious hyperinsulinism? Factitious is, the word factitious means false, or it is called pseudo. Here, the hyperinsulinism, it is caused by self-administration of insulin or ingestion of equal or oral sulfonylureas. See, these sulfonylureas, they are insulin secretagogues, in the sense they stimulate the beta cells. So, they will cause increase in the insulin secretion. Right? They will cause increase in the insulin secretion. So that is called factitious hyperinsulinism. And it is common and exceeds the incidence of the insulinomas. Insulinomas, they are very rare, but this factitious hyperinsulinism is very common. It is usually seen in the healthcare individuals or in those individuals who have the access to the insulin if any of the family member is suffering with the diabetes mellitus. So this is about factitious hyperinsulinism. Now, what is the triad of exogenous insulin administration? The triad include, number 1, hypoglycemia. Number 2, there will be increased insulin. Number 3, suppressed plasma C-peptide. These 3 are pathognomic of exogenous insulin administration. Right? These 3 are pathognomic of exogenous insulin administration. Right? Next. Now the question is, ethanol will cause the hypoglycemia. How does the ethanol cause the hypoglycemia? Ethanol at a concentration of 45 milligrams per deciliter can induce hypoglycemia by blocking the hepatic gluconeogenesis. Now, what is gluconeogenesis? It is a it is a condition where the non-carbohydrate moiety is converted into carbohydrate moiety, is called gluconeogenesis, and that is being inhibited by the ethanol. And ethanol induced hypoglycemia can also occur with prolonged starvation, right? Can also occur with prolonged starvation. When glycogen reserve becomes depleted in 18 to 24 hours, and hepatic glucose output depends completely on the gluconeogenesis. So basically, if the gluconeogenesis does not occur, the blood glucose which is released into the circulation will not be there. And what is your ethanol doing? Ethanol is blocking the gluconeogenesis. So the glucose output into the circulation will not be there. Right? Next. Now, you see, these 3 important scenarios you will be able to differentiate. That is insulinoma, exogenous insulin, sulfonylureas. In all these 3, the insulin levels will be high. Right? In all these 3, the insulin level will be high. In fact, if you take in case of exogenous insulin administration, the insulin levels may be almost more than 1000 microunits per ml. Right? More than 1000 microunits per ml. And the pro-insulin will be increased in case of insulinoma, because in insulinoma it is a tumor of the beta cell, and beta cell will produce the pro-insulin, and that pro-insulin will break into C-peptide and as well as insulin. So pro-insulin levels are increased in insulinoma, whereas they are normal in case of the exogenous insulin and as well as with sulfonylurea administration. And what about the C-peptide levels? The C-peptide levels, they are increased in both, that is in insulinoma and as well as with sulfonylureas. Why? Because the C-peptide is the one which is being produced along with the insulin, and in insulinoma and as well as sulfonylurea, the C-peptide is produced along with insulin, so the C-peptide levels are high. Whereas exogenous insulin, whatever is being administered, that does not contain the C-peptide, right? That does not contain the C-peptide, and that is the reason why the C-peptide levels, they are normal. And coming to the insulin antibodies, the insulin antibodies, they may or may not be present in individuals who are taking the exogenous insulin. Usually the insulin antibodies, they are present in type 1 diabetes mellitus. Then plasma or the urine sulfonylurea. So where is that the sulfonylurea levels will be elevated in the urine or plasma? That is in those individuals who are taking sulfonylureas. And what are the examples of the sulfonylureas? That includes glimepiride, gliburide, glipizide, gliclazide, and then glibenclamide. So these three are the causes for hyperinsulinemia: insulinoma, exogenous insulin, and then sulfonylurea administration. Now let me just take a clinical recall. Which of the following medication is contraindicated in patients with acute pulmonary edema with an ejection fraction of 25%? Glyburide, metformin, rosiglitazone, exenatide, sitagliptin. So the answer to this question is rosiglitazone. So in these individuals, they have the pulmonary edema, right? In these individuals, they have the pulmonary edema. So rosiglitazone, which is nothing but thiazolidinediones, they will cause the fluid overload. Right, they cause the fluid overload. So because they cause the fluid overload, that will make the individual to land up in the pulmonary edema. So that is the reason why in patients with pulmonary edema with ejection fraction of 25%, thiazolidinediones, that is pioglitazone and rosiglitazone, should not be given. Right. So that is about the topic of hypoglycemia. Thank you very much.